Okay. Good evening to all of you. This is a topic that is upcoming and maybe the topic of the future because we all know that sepsis is a very important clinical entity that we have been diagnosing in the past few years. And the diagnosis of sepsis has been changed by the discovery of biomarkers. And that is why I thought that this topic is relevant not only for today, but for all of you who are going to practice in future also. This topic is very, very important. So let's begin with saying what is the definition of sepsis. The 2016 Surviving Sepsis Campaign guidelines define sepsis as a life-threatening organ dysfunction caused by a dysregulated host response to infection. Now, a very important change happened with this definition, because so far we were always thinking that sepsis is about the bacteria, sepsis is about the microbe, and so you have an infection caused by an organism, and that is what we thought as sepsis. But over the last 2 decades, a complete change in the understanding of sepsis has happened, that sepsis is as much about the organism as it is about the host. So if you see this definition here, it's a dysregulated host response to infection. So it's not the infection. Everybody can get an infection. People can get a pneumonia. People can get, urinary infection. People can get malaria. Everything is possible. But the point is, there is a dysregulated host response to infection, and that is causing organ dysfunction. So the whole thing has changed from the being about the bacteria and the organism and whatever to the host response. And this is where biomarkers will come in, and that's why we are going to talk about this. Now, why do we need biomarkers in sepsis? We all know that the 2018 update talked about the 1 hour rule, that once you make a diagnosis of sepsis, immediately you have to intervene. Within 1 hour, you have to start your treatment. So every hour of delayed treatment in sepsis, mortality rises by about 30%. So here, time is life here, right? So the diagnosis of sepsis should be done, and should be done very early, and intervention also should be done very early. So let's see whether we can make this diagnosis in 1 hour or not. Now, how do we make a diagnosis of sepsis? We make a diagnosis of sepsis by, the gold standard is to demonstrate the presence of the organism either in the blood or the body fluids. Somewhere you have to show that this is because of an infection, right? But we all know that the turnaround time for diagnosis of any infection can be up to 24 to 48 hours. If you're growing a culture, you can't make the bacteria grow in 1 hour. Maybe you can diagnose a malaria fast, maybe you can diagnose some other diseases fast, but you can't diagnose a bacterial infection so fast. And even after you do the cultures, the culture is positive only in 30 to 40%. So even if everything is right, okay, you've done the culture right, even then the positivity is low. Plus, we all know that sepsis is a syndrome, and many times you have a problem differentiating an infection from a non-infectious condition. For example, if you have a pancreatitis, you have other conditions which are causing, sepsis-like syndromes, then we need to know whether it's an infection or not to start the right therapy. And a non-infectious condition, if missed, can cause more mortality. Like I said, if you have a pancreatitis and you miss it, you may lose the patient to pancreatitis by thinking that he is sepsis and giving him some antibiotic and not doing the right thing. So, given that you have to make a diagnosis fast and you have to intervene very fast, and that makes a huge difference to the patient's morbidity and mortality, you need something that will give you a diagnosis very fast. And that is where we thought that biomarkers will step in and make a difference to the diagnosis. So let's see how we can look at this. So where do these biomarkers come from? The biomarkers come from the host. The host produces these biomarkers, from the innate immune system receptors. So we have the DAMs and the PAMs. That is the damage or infection associated molecular patterns, and you have the pathogen associated molecular patterns. So the immune system produces this, and these release pro-inflammatory cytokines and molecules into the body. And that you are more familiar with these probably. Tumor necrosis factor, interleukin 1 beta, CRP, procalcitonin, then mid-range pro-ADM. All these are your pro-inflammatory cytokines which are released. But they are all coming from the host, by the host immune system, which causes the DAMs and the PAMs, and they act and release the pro-inflammatory cytokines, which are your biomarkers to the presence of sepsis. So there is an infection, there is a host. So the host responds to the infection by producing the DAMs and the PAMs, and that releases these biomarkers. So indirectly, by looking at the biomarkers, we are going backward and making a diagnosis of the infection that is present. So let's look at again where we are as far as the infection is concerned. If you look at the biomarkers for sepsis, we began with saying fever and leukocytosis are the features of a sepsis. But if you look carefully, you will find a lot more happens here. So you have sepsis, you have septic shock, you have sepsis-associated encephalopathy. So for sepsis and septic shock, it is coming from the PAMs, and for the sepsis-associated encephalopathy, it's coming from the DAMs, the damage-associated molecular pattern. This is the pathogen-associated molecular patterns. So these give rise to release of complex protein systems, which are either acute proteins or complement system or the coagulation system, or they are acting on the immune cells like your polymorphonuclear neutrophils, the lymphocytes, and all of them give rise to this host of biomarkers that you're seeing below this. I think some of them are familiar. Your CRP is familiar. You have the procalcitonin coming here, and there are many others which we will talk about. So these are produced from the liver or from the blood or from the immune cells or from the vascular tissues, or they are coming from the neurons or the glial cells. So you can get many biomarkers which are coming out from various parts of the body, and the presence of these biomarkers leads to, ultimately, the sepsis leads to organ dysfunction. Remember, your SOFA score is nothing but the measurement of organ dysfunction. So ultimately, the patient dies not because of the infection alone. It is because the infection is causing a dysregulated immune response, which is causing organ dysfunction. That's how he dies. And to find out the presence of sepsis, we are using these biomarkers because they are faster than your usual cultures. Their turnaround time is much less, and you can get some guidance as to whether your patient is better or not. Okay, so this is the whole overall view of what happens in a sepsis. Now, where are these biomarkers coming from? For example, the CRP comes from the liver. Okay, then you have the monocytes, the macrophages, the neutrophils. All of them are producing STREM1, presepsin, CD64, SUPAR, and you have the procalcitonin, which is produced by many cells. Okay, the parenchymal tissues, from the gut, from the lung, from the kidney, from everywhere, the procalcitonin comes out. So there are the host immune cell, of course, produces IL-6, which acts upon these cells. So there are many biomarkers coming from various parts of the body, and these are all present in the blood. Now, what is, in your idea, an ideal biomarker? If you want an ideal biomarker, it should be able to distinguish between infectious and non-infectious conditions. That's the first criteria. It should be a point of care test, which can be easily done in the emergency department. It's something that you should be able to get easily. It should have a high sensitivity and specificity and reasonably short turnaround time. It should be able to predict severity of disease and prognosis, including mortality. So this is what we would like a biomarker to do. That it should say whether it's infection, it should be fast done, should have a good specificity, sensitivity, and it should be able to predict the prognosis of the disease. This is our wish list. And of course, we want more. Then we want the biomarkers to tell us whether we can detect it early, whether it can differentiate different causes, and different phenotypes about which I'll talk a little later, whether it can guide the response, whether you're giving the correct treatment and the patient is responding or not, whether it is able to say that, and whether it can detect and predict complications, and of course, provide the prognosis. This is the wish list. This is what we as clinicians want from a biomarker. But as we can all see, the ideal biomarker doesn't exist. Okay. So, like everything else in life, there is no ideal anything. So what we have to do is we have to make the best of the imperfect things that we have. So that is when we should understand how these biomarkers can be used in the diagnosis of sepsis and where are their positive points and where are their negative points for the diagnosis of sepsis. So in this talk, with this introduction, we will go into these biomarkers: procalcitonin, C-reactive protein, pre-sepsin, SUPAR, and proadrenomedallin. Okay, so I'm not covering all the biomarkers. I'm just picking up these which are more often used, and some of them are upcoming. So the first is the procalcitonin. This is a hormone which became a cytokine. So we all know that procalcitonin comes from the seed cells of the thyroid, and normal physiology, this procalcitonin will be converted to calcitonin. And so that is why you do not see procalcitonin walking around in the blood, because it's all converted to calcitonin, and the normal level must be less than 0.5. Some people say even 0.25 nanogram per ml. But what happens in the presence of infection is different. In the presence of lipopolysaccharides and microbial toxins, IL-6 and all, this procalcitonin goes directly into the bloodstream, okay? And that is how you are detecting procalcitonin. And initially, like we said, it is produced in the thyroid, but in the presence of infection, everything starts producing procalcitonin from the WBCs, kidneys, spleen, adipocytes, everything starts producing procalcitonin. So this is a hormone that became a cytokine, sometimes called a hormokine also. So this is the commonest biomarker that we are using. In our ICU here, we regularly use procalcitonin to diagnose sepsis. So let's look at where do we position this procalcitonin. Now let's look at this problem. A 65-year-old lady comes with high-grade irregular fever. She has a familial right lower limb which is infected and pus is oozing. Her TC is raised, neutrophilia is there, suggesting a bacterial infection. Procalcitonin is negative. Okay, procalcitonin is negative. Should this patient be given antibiotics? Can you please answer on the chat box? Definitely yes. Okay, some people are saying yes, ma'am. Right. Okay, fine. Sorry, I didn't open that. Right. Okay. Okay, so let's look at the answer. Of course, she should be given antibiotics. Okay, now that brings us to the question: what does procalcitonin miss? What are the things that procalcitonin can miss? Okay, even in the presence of infection. So in that, you know that you have local infection like abscesses, procal will be normal. So you cannot go with the procalcitonin for a local infection. Even in an empyema, which is a walled-off abscess, procal can be normal. Appendicitis, which is again a local infection, procal can be normal. And of course, if you have a bad host, for example, you have somebody with HIV, you have somebody with steroids, immunosuppressive agents. Now, all these people also, procal can be normal. So remember, the procalcitonin does not rise in a localized infection. Procalcitonin rises only when the infection is systemic and spread. And procalcitonin also depends upon the host response. So in a HIV patient or patients on steroids or immunosuppressive, procalcitonin can be negative. Now let's look at the next problem. 65-year-old diabetic has an RTA causing blood loss. He has hypotension, total count is high, he is afebrile. Creatinine is 4.2, RBS is 320. Okay. Procalcitonin is 5. Does he have sepsis? Should he be started on antibiotics? This patient had a trauma and then he's come with hypotension, and then that is what is happening to him. And he has got creatinine which is high. So what I'm asking is, should this patient be started on antibiotic? And yeah, should he be started on antibiotic? This patient, So you're all saying, yeah, you should be started on antibiotics. So let's look at the answer. No, not on the basis of this procalcitonin. Okay. Now this patient had an RTA. He came to you with hypotension. He had a creatinine which is raised. His procal is high. Okay. Does he have sepsis? I don't know. Okay. So let's look at what are the false positive or the non-infectious conditions where procal can be positive. First on the list is trauma. So even in a trauma, you can get a high procal. It does not mean that there is a bacterial infection or any infection and that there is a sepsis. Major burns, multi-organ failure, any shock, stroke, surgery, inflammation, renal failure. So in the problem that I gave you, I had put a trauma and I had put a renal failure also. Remember that in renal failure, procalcitonin can be high without the presence of a sepsis. Okay. So renal failure because of any condition, procalcitonin can be high. Okay. So many of these conditions like post-surgery. So these are pancreatitis. These are all the conditions where there are false positives for the procal. Okay. So you have to interpret it in context. So meta-analysis of, so many studies showed that procal, the specificity and sensitivity of procalcitonin is 74%. Now, what does that mean? Let's say 75, just to round it off. 1 in 4 cases of sepsis is missed by procalcitonin, okay? Or infection is missed by procalcitonin. 1 in 4 is wrongly diagnosed. Remember, the specificity and sensitivity of procalcitonin is 75. So you cannot believe it 100% and you cannot say just because the procal is positive, he has got sepsis, or because it's negative, you ignore the infection or the sepsis. It can miss. It is never 100%. Now let's look at the next question. Can it differentiate between infections? Procalcitonin does not rise in viral infections as interferon produced by viruses can decrease the TNF alpha, which stimulates the production of procalcitonin. Okay, so that is why in a viral infection, procal need not rise because the interferon decreases the TNF alpha. The TNF alpha is the one that stimulates the PCT. So because that is depressed, that's why procal need not be positive in a viral infection. So when you are in doubt whether this is a bacterial infection or a viral infection, to some extent, yes, procalcitonin can give you some clue as to the presence of a bacterial infection. It rises more in gram-negative infections than gram-positive infections, okay? So gram-negative infections somehow cause an increased procal compared to gram-positive. And Candida species, pneumocystis, malaria, leptospirosis, remember they can all increase the procal, okay? So don't think it is only bacterial. It can go up in many other conditions. But fungal infections and viral infections, the procalcitonin does not increase so much as we think, okay? So fungus and virus may be less, but all other infections, it can go up. And that is why we must remember that procalcitonin is not without its fallacies, but is useful for the diagnosis of bacterial infections, and more higher levels and more rise is seen in gram-negative infections. Does absolute value reflect severity? No. No, it does not. Suppose you have a procalcitonin of 50 and a procalcitonin of 25. You mean to say the 50 man is sicker than the 25 man? Need not be. Need not be. It's never a measure of severity. But in the presence of septic shock and bacteremia, procalcitonin is higher. For bacteremia, procalcitonin has excellent negative predictive value of over 98%. Okay. So in the presence of bacteremia, your procalcitonin is definitely positive. So if it is negative, then you probably don't have bacteremia. That you can tell. Okay, that you can tell. So that's what it means. So absolute values are not important, but definitely more tendency to go up in the presence of bacteremia and more tendency to go up in the presence of septic shock. But the real value of procalcitonin, is in this thing of de-escalation. When you want to de-escalate the antibiotic, that is where your procal is very important. So if you see the response of the bacterial infection to procalcitonin, so if the bacterial infection is there, you give the procalcitonin, then the procalcitonin level dips. Okay, so you can use it for finding out that your patient is responding to your antibiotic Yes, that you can do. So this is again Cochrane database showing the 12 studies which are published between 2007 and 15 in the ICU. They showed that the duration of antimicrobial therapy can be made shorter if you go with the procalcitonin because you will de-escalate faster. Okay, so it's useful for de-escalation, and we will see why. This is again another study which is talking about the meta-analysis in patients with bacteremia. When you're going with the procalcitonin and coming off the antibiotic, you are decreasing the antibiotic exposure. Remember, we all now know that antibiotic resistance is a major problem. And one of the main causes of antibiotic resistance is the duration of antibiotic. All of us tend to say, give it 2 days longer, give it 3 days longer. And this is how we produce resistance to antibiotics. So whenever it is over, we should be able to say, come out of the antibiotic. That decision must be taken, and that can be guided by the level of procalcitonin. This again a Lantis study which showed that the procalcitonin guided strategy was able to bring down the exposure of antibiotics without adverse events. What I'm saying is that just because you brought down the antibiotic, patient became sick, that didn't happen when you are guided by the procalcitonin. So you are having a good biomarker which is telling you when to come out of an antibiotic. So this is some algorithm which can be used when you want to come out of the procalcitonin. So if your procalcitonin is low, then definitely come out of your antibiotic. Then if it is more, then definitely and it is dropping by 80%, then you can come down. Okay. And it is not dropping, then you probably have to continue. But if it is rising, then you don't discontinue your antibiotic. So the idea is that a dynamic procalcitonin is probably more useful than a single value. For example, when you want to come out of the antibiotic, it gives you the confidence, especially if there's a good drop of about 80% of the procalcitonin and it is coming down to lower levels, then yes, it's good time to stop your antibiotic. So different cutoffs are given, but generally 80 to 90% decrease, it's not an absolute value. And of course, the patient must improve. And many clinicians will hesitate. If the patient is unstable, nobody is going to go and remove that antibiotic. Okay. So it's a clinical judgment, but procalcitonin is a very good marker for you to tell that there is adequacy of treatment and the infection is subsiding and you can de-escalate on the antibiotic. Now, does it affect prognosis? Yes, the fall predicts improvement, okay? And the increase predicts deterioration. And mortality also, yes. So there are large studies, again, on RCT, which showed that less than 20% decrease from day 1 to day 4, that there was a higher mortality in these patients. So if somebody's procalcitonin is not coming down as expected, it is not decreasing by at least 20%, then the mortality is higher at 28 days. And if it not declined by more than 50% compared on day 1, day 0 and day 4, then again you have a problem. So what is important is the dynamic change. How much does the procal increase by or decrease by, and day 0, day 4, day 7, like that, that will give a good idea of the prediction of the improvement or deterioration of the patient. So the bottom line about procalcitonin is don't start antibiotics based on procalcitonin. Remember, sensitivity and specificity is only 75%. End because of procalcitonin, because procalcitonin is come down or it is at 80% decrease or it is less, you can end your antibiotic. It's a biomarker for de-escalation and stopping. And of course, clearance over time, the dynamic change can predict mortality. Somebody's procal is going up, then the mortality is going to be higher in that patient. That you can think of. So that's about the first biomarker that we talked about, procalcitonin, which is often used. We move on to the second biomarker, which is a C-reactive protein, which is available in many, many places, and it can be used as a nice biomarker for the presence of infection and sepsis. So we all know it's produced in the liver. It's in response to infection and inflammation. IL-6 and IL-1 regulated, and we know the normal level. Each lab is different, but generally less than 3 is normal. Now let's compare the CRP with the procal. Is it as useful as the procal if you look at it? If you look at the sensitivity and specificity, the sensitivity of the CRP is 0.8, whereas the specificity is 0.61. Okay, so it picks up infection but its specificity is poor because it can go up in many other conditions. So definitely it is not as high as, especially the specificity is not as high as a procal. The poor specificity is because it can go up in many inflammations. So you can't really rely on a CRP to make a diagnosis of sepsis, because it can go up in all the collagens, so many things can go up. Any inflammation can go up. The other thing is the CRP rises in 1 to 2 days, and you cannot use it for a diagnosis. Cannot, because it is going to take time to go up. More than 50 is probably always bacterial infection. So the height of the CRP does tell you the presence of bacterial infection. The fall also occurs slowly, so can't use for de-escalation. You can't go with that because the procal rises and falls faster. So that can be used for de-escalation, this cannot. And it's unreliable in liver disease. So there are many problems by using CRP. The first one being the specificity being so poor, and of course the slow rise, the slow fall, and the unreliability in liver disease. So remember that the CRP versus procal is like an elephant versus a rabbit. The CRP rises slowly, comes down slowly, walks slowly. Whereas the procalcitonin is like the rabbit, goes up fast, comes down fast. So if you look at the dynamics here again in this chart, you can make out the procalcitonin is the one that's going up here. The blue line is the procalcitonin. You can see the blue line there. That's a procalcitonin. That is a CRP which rises and peaks much later. So remember that the procal can go up in about 6 hours and peak in about 24 hours, whereas the CRP peaks at 1 to 2 days. Again, the fall also, procal will fall once you start treatment within 24 to 48 hours. The CRP may take 2 to 3 days to fall. That's a difference in the biomarkers, and that's how you're going to use it for the diagnosis and for the de-escalation. Now, this is a chart which compares the two important things, that the C-reactive protein and the procalcitonin. We know this is a acute phase protein. This is a harmokine. These are the normal values. The maximum peak is given here. The source of this is the liver, okay? And this can come from virtually all cells. And this takes time to peak. This is peaking very fast, the procal. And of course, look at most of the other things. Steroids, immunosuppression, neutropenia has no effect on this. Frequent false negatives can come because you're knocking out the host. Renal failure has no effect on CRP, but renal failure has an effect on procal. Remember the problem which I showed you, where there's renal failure, the procalcitonin can be high even without the presence of sepsis. Whereas renal failure has no effect on CRP, but the liver failure, definitely CRP will not go up, whereas liver, the procal doesn't affect. So there are many differences between the two, and if you can use it judiciously, you can use them as good biomarkers. In CRP, it's definitely high in bacterial sepsis, and of course culture positive cases higher value, predicts more severe organ dysfunction. Fall with therapy reflects efficacy, but remember the specificity is poor. So one of the things that when we read all these studies about comparison of the biomarkers, there are so many. If you just Google it up, you'll find 100, 200 studies on biomarkers in sepsis. If you look at the fine print, you will find that the way they diagnose sepsis is different in each studies. And when they are comparing a biomarker, whether they use the biomarker for septic shock or they use for severe sepsis, what was the SOFA score, these things are not very clear. And sometimes you can't compare two studies because one has used one definition and one criteria, the other one has used another definition and another criteria. So remember, when you're reading these studies, you remember that sepsis is a syndrome. It's not a disease. So the inclusion-exclusion criteria decide many of the results that come out of that study. So when you're reading these studies, use caution and read well. Moving on to the third biomarker that we know of, that is presepsin. Now, presepsin is formed by the cleavage of the soluble CD14. You can see the CD14 here, which is a toll-like receptor, member of the toll-like receptor. That's a toll-like receptor. That is a CD14. The bacteria comes in and along with the LPS forms a complex, and then it is broken down. That complex is broken down and you get the presepsin. So the interaction of the bacteria with the monocyte or macrophage causes this toll-like receptor to get activated, and the CD14 comes in, and then that is cleaved to form the pre-sepsin. So this is another biomarker. Now, if you look at the sensitivity and specificity of pre-sepsin, it's not too bad. It is 86 and 78, and less than 200 picograms exclude sepsis, more than 1000 confirm severe sepsis, and to some extent, it can differentiate between patients with sepsis and septic shock. So it may be a marker for the future because you can see the red line here. Now that is the pre-sepsin. The ROC is good for pre-sepsin, for the septic shock and the mortality. For both, it is good. And you can see here the difference between patients in pre-sepsin in septic shock and between survivors and non-survivors. You can find that the numbers are different. And so that is how it is useful as a biomarker to predict. But can predict prognosis and is an upcoming biomarker. But you don't have many studies on it. That's why I'm not really focusing on it. The next one is SUPAR, which is soluble urokinase type plasminogen activator receptor, which is SUPAR, which again comes from the immune system. And you can see the SUPAR which comes here. You're all familiar with the UPAR, the urokinase plasminogen receptor activator, and then that is cleaved and forms the SUPAR. And the SUPAR has many actions, like it causes chemotaxis, angiogenesis, phagocytosis, etc. All these things are part of the inflammatory response to an infection. And so SUPAR has also been tried as a biomarker. And if you look at the functions of SUPAR, you will find that it's got many functions. It's got a neutrophil function, scavenging function, angiogenesis, regulation of chemotaxis, etc. Many things are there. And it positively, it shows you that the immune system is activated. That's all it tells you. So it shows you that the immune system is inflamed, activated, whatever, and can be an indicator of disease severity and aggressiveness. So again, if you see the ROC for the SUPAR, it is good for predicting mortality. So it's a good thing for telling you the aggressiveness or the degree of activation of the immune system. There are other biomarkers like CD64 and STREM1, but the studies that are there for these are not very convincing. So that's why I have not gone into that. More and more data is emerging, and probably at some time in future, we will get more studies on this, and these may be used in the future. One exciting thing is what we call as adenomedullin. Now, adenomedullin is an important role in inflammation and for the progression of sepsis to septic shock, because this adenomedullin, as the name suggests, was found first in the adrenal medulla. But later on, they found that it's there everywhere, and it is mainly acting on the vascular system and plays its part as a vasodilator, inotrope, diuretic. All these are the functions of this adenomedullin, and is produced by all cells. Though it began by saying it's produced in the adrenal glands, that's why it's called adenomedullin, but it is actually produced now by all cells. And the main action is the progression to septic shock, which is what most of us are worried about. This proadenomedullin is a vasodilatory peptide which is produced by the adenomedullin and is elevated in sepsis but rapidly degraded. So these levels predict, if their adenomedullin levels are higher, it predicts a fatal response. And the specificity and sensitivity are good for proadenomedullin. It's a biomarker of the future. Further going down the line, you know that you get microRNAs everywhere, right from diabetic complications to nephropathy, neuropathy, for everything, cardiac failure, so many biomarkers have come, which are all microRNAs. So this microRNA, which is mentioned here, is also a new potential biomarker for sepsis. So when you're asked a question in the exam for biomarkers in sepsis, all these must be mentioned because these are all upcoming biomarkers. Now let's look at whether we can predict the prognosis. Please remember that sepsis is multifactorial. Prognosis depends upon patient's profile and comorbidities and the virulence of the organism, organ dysfunction. So though we are saying so many things, no biomarker can accurately predict what's going to happen. All of them are pointers towards, like what we said about proadenomedullin, towards progression to septic shock, etc. SUPAR is a good one. Pre-sepsin is a good one. But these are all, the data is just accumulating now. But so far, nothing is very good. And like we said for ProCal, the dynamic change is probably more important. Now, I want to end the last 5 to 7 minutes with some very interesting questions on biomarkers. Now, can we predict with biomarkers which patient will go into complications? Can we predict that? That is where we come to precision medicine. And we know that in sepsis and septic shock, like we said, the host is totally different. Each host is different. So can we judge? Now, this patient will go into this complication. Can we say that? So there is very exciting data in this field. So there are studies which show that there are phenotypes or endotypes of patients who have a propensity to get an acute kidney injury in the presence of sepsis. So if you have a sepsis, you can say that this particular person will probably go into an acute kidney injury in which endothelial dysfunction may play a role. So there are studies, but if you can identify these people will go into a kidney failure, then you can do the preventive strategies in them. So a biomarker is no more used for the diagnosis. It is used for the prediction of a complication. So that's a very exciting field. Again, we have the presence of biomarkers, neurofilaments as biomarkers in sepsis-associated encephalopathy. We all know that sepsis-associated encephalopathy is a big thing. In the ICU, if you have a patient who is unconscious and who's got sepsis, then you say probably tomorrow sepsis will get better, encephalopathy will improve, patient will become conscious, isn't it? So this is because there are sepsis biomarkers which are present in the brain. And there are studies on neurofilaments in the brain which can be used as biomarkers for sepsis-associated encephalopathy. So that's a very exciting field again. Lastly, can biomarkers used to tailor treatment? Can we use them for treatment, for therapy? Let's look at this. This is a very interesting prospect. Now, we know that when we have patients with sepsis, some of them have a hyperinflammatory state, some of them are hypoinflammatory. So in some, the immune system is very much activated. In some, there is an immune paralysis. We all know that both types happen in sepsis. And if we can identify them, because the treatment is totally different. If you have a hyperinflammatory state, then you would use the steroid. If you have a hypoinflammatory state, you would give an immune stimulation. So this is very important. If we can identify, if we have a biomarker, which will tell us what kind of an inflammatory state is this person in, then your treatment could be totally different. There are efforts to find out this, but so far nothing has come out very concrete, and that's why I'm not mentioning. But this is precision medicine in the making. Now, very interesting again is this VAST trial where we use vasopressin for septic shock trial, in which they sub-analyzed a group of patients. A subgroup analysis was made using biomarkers, and they found that one subphenotype had a strong benefit to the use of vasopressin. So some people responded very well to vasopressin, some people did not. So this again is very exciting, because if you can predict in the ICU which patient is going to respond to vasopressin, that will help you to tailor your the inotrope accordingly. So here we are using a biomarker as a means of identifying who will respond to what treatment. Now, lastly, there is a monoclonal antibody, which is adrisizumab, which is directly linked to intravascular ADM, your adenomedullin, and it prevents the leakage of this ADM into the extravascular space. So, by giving this monoclonal antibody, which forms a complex with the ADM, and it extends the half-life of ADM, and the functional activity stabilizes the vascular endothelium. So now you're using a biomarker and you're using a monoclonal antibody to it, and you're improving the prognosis of the patient. However, this study did not reach statistical significance. This was from 2021. Of course, more and more studies are coming up like this. So a biomarker starting from being a diagnosis has become something that can predict a prognosis or a complication, or even can be used as a therapeutic target. So to summarize, biomarkers have their place as supportive tests in the diagnosis of sepsis, but their fallacies must be understood. You must know how to use them, otherwise you'll keep on making wrong diagnoses. Procalcitonin is good for de-escalation, CRP also useful, presepsin and SUPAR are new markers. Future is biomarkers can be used for identifying complications, which is very exciting, and identifying sepsis phenotypes is very, very useful to us. May become the basis of precision medicine and targets for intervention like pro-ADM. So the future is very exciting for biomarkers. And that's what I would like to conclude with. Thank you all for a patient hearing. There are any questions I can take. Okay, somebody. Okay. Are there any questions? Okay. Okay. Right. Somebody asked about when do we give steroids in septic shock? Steroid in septic shock is a topic that has come, gone like that. Now, we do give steroid. I do use steroids in septic shock. When do I use it? When I find the response to inotropes is not very encouraging. Suppose I've used 2 inotropes, I'm going on to a third one. Then I do use the septic dose of steroids. I give the hydrocortisone 50 milligrams IV 6th hourly for patients. Now, there are 2 reasons to give it. One of the reasons is probably simple. That is when you have an endothelial so you got a septic shock and your endothelium is not responding to your inotropes, then we can give the steroid because the steroid makes the endothelium more responsive to inotropes. So it enhances the sensitivity of the vascular endothelium to inotropes. For that, steroids can be given. The second indication is more controversial. Now, they say that in the presence of sepsis, you have a functional adrenal failure or a relative adrenal failure. So there have been efforts to make out whether by measuring the cortisol levels during 1 minute, measuring the cortisol levels and finding out whether people who have low cortisol, only in them we should give steroid, and people who have good cortisol need not give. Like I mentioned, the endotypes which are different. Some people have a hyperinflammatory response, some people have a hypoinflammatory response. So that is still not made out, okay? But there are studies like that, but it was found that the measuring the cortisol level in the presence of sepsis was useless. The data fell on either side, so nobody could understand what was happening. That's why the surviving sepsis guidelines ultimately said, no, don't worry about who the patient is, just give the steroid for increasing the sensitivity of the vascular endothelium to inotropes, and then give the steroid, whatever it may be. That was the consensus, and that's how we give. Now, somebody asked me, is early steroid better? No. Early steroid is given in 2 conditions. One is in meningitis, one is in pneumonia. Both of them are for, decreasing the inflammation. But there is data only for pneumococcal pneumonia, and there is data for only a meningitis, pneumococcal meningitis. So those are all not indications for sepsis as such. And there you are using a dexamethasone. You are using a inflammatory, a steroid with the highest inflammatory response, anti-inflammatory response you are using there. Whereas in sepsis, you are using a hydrocort, completely different, okay? So early steroid is not for sepsis. Now, at what intervals do you check the procalcitonin? Maybe 3 to 5 days. 3 to 5 days would be ideal, especially when you want to come out. That's when you check. When you're scared of coming out, and then you think that maybe a procal will help you to make your, give you more confidence to come out. That's when you check.